Hi, everyone. Let's see. Okay. Well, it's 11 o'clock, so we are going to get this webinar started. Thank you, everyone, for joining us on your staycation, COVID-19. We are excited to have Dr. Naz with us. She's Natalist Chief Medical Advisor and a practicing OBGYN. She is here to answer all of your questions. A lot of you guys sent questions in advance. Thank you. We will start with those. But if you have anything else that comes up, please just use the chat function to drop in questions that may come up during our talk. We are excited to kind of have Naz again. We did a webinar 2 weeks ago now, and Dr. Naz got most of the questions, so we figured having her do a solo webinar would be a great option to kind of dive into getting pregnant and being pregnant during this pandemic. So with that, I think we should just dive in. So we'll kind of group this into 3 buckets. First, we'll talk about trying to conceive during COVID-19, and then we'll move on to questions around pregnancy during COVID-19. And then we'll leave the last portion, just any questions that you have that you want to get answered. So with that, Naz, do you want to talk about trying to conceive during COVID, if it's safe, if people should consider putting their plans on pause, and then maybe talking a little bit about what people who are getting fertility treatments should consider?
Sure, absolutely. And this is a question that we're getting a lot these days, and obviously on the top of many people's minds. One, I want to take a second to apologize for my eyebrows right now. As everyone knows, this is maybe one of the, I know there's a lot going on during this pandemic. I am personally mourning the loss of the woman who threads my eyebrows so well.
My split ends, they forgive your eyebrows.
We're all going to be a little bit more forgiving this today and every day going forward. So in regards to trying to conceive in this time, it's important to note that the American College of Obstetrics and Gynecology has made no comment that says that patients shouldn't try to conceive spontaneously right now. And so I think I want our patients to hear that there's nothing that says that you can't try if you want to, but we do know that the American Society of Reproductive Medicine did come out with a statement. The original recommendations were made on March 17th, and they were reaffirmed on April 13th, that all new treatment cycles should be suspended, including ovulation induction, intrauterine insemination, in vitro fertilization, including retrievals and frozen embryo transfers, as well as all non-urgent oocyte cryopreservation, so egg freezing. And they also said to strongly consider cancellation of all embryo transfers, whether fresh or frozen, to continue to care for patients who are currently in cycle, who require urgent stimulation and cryopreservation, and to suspend elective surgeries and non-urgent diagnostic procedures, so that would be like imaging studies or lab studies, and to minimize in-person interactions and increase the utilization of telehealth. So this has effectively meant for our community that was going to use assisted reproductive technology, that's all for the most part been halted. But for people who want to try on their own, they're welcome to. I would say that one of the things that we also have to consider during this time is, how do you emotionally and psychologically feel right now? It's all, yes, we know that you're able to conceive, but in light of everything that is happening in our nation in terms of like the recession and many people facing layoffs, you have to decide for yourself that whether you and your partner feel like it's the right time to proceed.
Think about just the timing of getting pregnant now and where we'll be in 9 months. Is there a risk that we'll see the same sort of barriers to getting prenatal care in 9 months?
I hope not. And I want to clarify, like prenatal care, I would say there are no barriers to getting prenatal care. And we can talk a little bit later about what prenatal care looks like right now. So I don't foresee any barriers to getting prenatal care. Having access to assisted reproductive technology, I think we are all hoping that in 9 months, that is definitely not going to be the case. I know there's active work being done with the ASRM task force to determine when it will be safe to proceed. And definitely, I hope that it'll be before 9 months. I think we're going to have to see what COVID-19 does in various parts of the country and where we can start liberalizing social distancing rules. So in that sense, I mean, I think at this point, we don't know. And that has been maybe one of the most frustrating parts for all of us, right? Is that right now, there are certain things that are still a bit unpredictable. I will say, like in our hospital, we've changed our policies multiple times in the past 2 weeks. And so I think, you know, it's important to keep in mind that we all have to be flexible in this time. And it's important to check in with your providers to see if there's any new updates. And hopefully, like forums like this will help provide our patients and our consumers with updates that they can take back and go to their physicians with. The one other thing I wanted to say that I forgot to mention is that, I mean, I think this is pretty intuitive, but ASRM did make a statement that said, if you think you're COVID positive, or are at high risk of contracting COVID because of, you know, your job or your exposure to other people who have had COVID, then it's not the ideal time to try.
Okay. And on that note, Kimberly is asking for people who have had COVID-19 but have recovered and have shown the antibodies, will they be able to do an embryo transfer?
Kimberly, I'm not sure. We don't know yet because we're still trying to determine what the significance of antibody testing is. So I know one of the questions we have is antibody testing, does it actually mean that it confers immunity in the future, like we know in the same way that we know that other antibodies do, because there's so many strains of not COVID-19, but coronavirus, we're not quite sure. So I think we're going to have to wait until, I know there's a lot of studies going on right now with antibody testing. We're going to have to wait until we get more information.
Okay. So you have a sister who is recently married. Not to put her on the spot, but if she wanted to get pregnant this year, what advice would you give her?
I would tell her kind of like what I mentioned before. You have to, do you feel ready? How would you feel about giving birth in these circumstances right now? That's one thing. Like, are you financially stable? And that's not something for me as the doctor to decide. It's just something I want my patients to take with them. And I'd want the same for my sister too. How do you feel about in this current setting of social distancing where we're asking you to limit your interactions with people? How would you feel about having a baby and maybe not having your parents or a doula or your sister be able to come and support you? In general, like I said, we know it's safe to conceive. We have limited data from people who have had SARS and MERS in the past that those viral infections did not confer an increased risk of congenital anomalies on the baby if the mom had it during the pregnancy. We don't know for COVID, but to determine that this would likely be the case for COVID. There is mixed data about what maternal fevers can do in early pregnancy, but in general, we think that it is safe. So I would tell my sister, like, if this feels like the right time for you and you want to try and have a baby, I mean, I do think we're going to be in a different place 9 months from now. I just really don't know what that place is going to look like. So we know that people are going to continue having babies. We're going to continue being able to support them. But how you feel as new parents in this environment is a decision that you have to make.
So there was an NPR article that came out yesterday that it really resonated with me. It said, women feel like they're falling off this fertility cliff. And there's a sense of like, especially when you're in your 30s, especially the late 30s, it does feel like every month your chances go down significantly. Everybody is very familiar with that chart that is everywhere about your fertility as you age. how much, if you do wait 3 months or 6 months, how much would that impact you and your chances of conceiving? Like, how quickly are you falling off this cliff when you're in your 30s?
Well, I think in your early 30s to 35, it's you're not quickly falling off. And honestly, I would want a reproductive endocrinologist and infertility specialist to weigh in on this to give you the exact numbers. But for someone over the age of 35 to like 39, I think what we would normally we should take the existing policies we had in place in mind. When we used to say, and the ASRM states that if you are over the age of 35 and you haven't conceived within 6 months, then that is the time that would be deemed acceptable to go see an infertility specialist and talk about getting treatment. Mm-hmm. So I think in that sense, like if you're between the ages of 35 to 40, and I really don't worry as much for the patients who are under 35 who have regular cycles, because chances are if they have no other red flags in their history, their chances of getting pregnant are high. But for people between the ages of 34 to 35 to 40, talk to your doctor. You can still have a telehealth visit. See what you can do to effectively try and get pregnant at home during this time, during this 6-month window. Make sure you're tracking your ovulation, make sure you're taking your prenatals, and have that timed intercourse so that, if you're not getting pregnant in that window, you can start planning ahead with your doctor and say, listen, when the fertility clinics open up, I'd like to get in as soon as possible. And another thing, fertility clinics are still seeing patients. They're doing telehealth visits. So if you are someone that's worried about your fertility, you can still, in most cases, schedule an appointment to speak to a reproductive endocrinologist and infertility specialist, get that background history, and plan ahead for when the policies are more liberalized.
Great. Okay. We have another question around embryo transfers. And Rose asked if we don't expect a vaccine for 6 to 24 months. Do you think an embryo transfer will resume before then? For example, might clinics open up after we pass the peak?
Yeah, similar to Kimberly's question, I think my hope is that embryo transfers will resume before we have a vaccine. I don't necessarily think we're going to be looking for the vaccine to be the option that decides whether or not we can continue elective surgeries. I think it's going to be more how effectively we've been able to flatten the curve. So I do think so, but as I've mentioned before, and it's going to be the theme of what I say, flexibility is key, and we are updating our policies weekly as we start getting more and more information from research that's happening. So in 2 or 3 weeks, if we repeat this webinar, I might have a different answer. But I do think that embryo transfers will likely resume before a vaccine, but we're just waiting to see at what point it'll be safe for the fertility clinics to open up their practices to performing these procedures.
I will say, well, first of all, we're going to move on to pregnancy. If anybody has any last questions around trying to conceive, please drop them in the chat now. And I will say, Naz, my fertility doctor is volunteering in New York City at a hospital right now.
Oh, amazing.
Yeah, which I really admire that he's doing that. I'm curious if other fertility doctors are doing the same. I think it's a good use of their medical degree, and it's obviously really needed right now. He's still available to me by text, which is really sweet, but he's kind of taking this time because he knows he can't see patients in person to help, which is great.
I think it's been amazing to see the response of our frontline workers or healthcare providers, so doctors, nurses, therapists, all of the environmental services individuals who really help keep hospitals functioning. I know UCSF just sent a team of 20 doctors and nurses to New York, and it's just, I think, listen, the physicians that you've been seeing, the midwives, the nurse practitioners, the physician assistants, we went into this field because we want to help people. And it feels there can be times that this now that we feel a little helpless, or we feel like we can't offer the services that we're used to providing. And I think it's amazing to see, Halle, like what your doctor's doing. I know our infertility specialists at UCSF have made themselves available to help us in ways that they weren't previously used to doing. But I think it's, everyone's stepping up, and it really feels amazing to see that.
The United Airlines video, did you see the video yet? Because it'll make you cry. They did a video like synopsis of the 20 UCSF doctors.
Oh, wow.
Getting on the plane. They had like, they did a special announcement. Everybody was cheering for them. It's definitely a tearjerker. Google it.
Too many occasions to cry. We'll save it for a feel-good moment.
Yeah. So before we move on to pregnancy, Lindsay does have one question. We kind of covered this, but maybe you can just give like a quick summary. She asked if you recommend people keep trying to conceive or take a break for those who are trying naturally without a treatment. If you can just summarize everything you said earlier for Lindsay.
Absolutely. And Lindsay, just so you know, there is a great article. I won't say it's great. I wrote it, but I think we answered this question. I hope it will be helpful for you. The long story short, the American College of Obstetrics and Gynecology has not made any recommendations that patients should stop trying on their own. But if you think you have COVID, or you're worried about the financial situation right now, or wonder like what if you'd want to get pregnant right now without the same support that you would normally have, then it might give you pause. But I tell my patients, if you want to try right now, go ahead. Absolutely.
Awesome. Okay. So we have one more question about TTC. K-Pat asked, how long before should you generally start taking a prenatal supplement when you start planning?
Absolutely. So we tell our consumers, and also I tell my patients in clinic, about 1 to 3 months before you start trying.
Great. Okay, so let's talk about pregnancy. We do have a couple of folks who are pregnant or trying to get pregnant in the room. So maybe we can just start with you sharing what's happening at your hospital with the patients right now that you're seeing that are pregnant. Can you walk us through that experience and how it's different from, say, a year ago?
Sure. So we have moved our model of prenatal care to include a lot more telehealth visits than we ever did. And I think I like to tell my patients that we're not reducing the number of touch points we have with you in the pregnancy. We're not trying to limit the number of times we see you. We're just trying to be smarter about how we do it. And in the long run, I actually think that this is going to be better for patient satisfaction. And what I mean by that is that at my hospital, we're trying to make sure that prenatal visits, we still have in-person prenatal visits, ones where the initial prenatal visit to confirm that the pregnancy is healthy and that it's in the right place, and to talk about genetic testing, and then the prenatal visits that incorporate the formal ultrasounds or the vaccinations or the ROGAM or the third trimester labs. But then we're trying to be thoughtful about when we can talk to patients over telehealth so that we minimize their exposure to COVID and we minimize our exposure to potentially someone who's positive. And so we have, I think Clio has done there's a startup called Clio, and they've done a really nice job they've made an infographic of how you can think about your prenatal visits if you're a low risk patient. But we have moved to that model, and I will say, I know there's a lot of education we have to do with our patients to let them know what to expect, but ultimately, I think it's going to be better for patients in the long run. The one thing we're telling our patients to do in order to prepare for these telehealth visits is to get a blood pressure cuff. And that's going to be a blood pressure cuff that you put around your arm, because the blood pressure is one of the most important vital signs that we get during your prenatal care. And the other thing is that when you get to the point of feeling fetal movement, we're going to rely on those kick counts to make sure that your baby is doing well too. And I want to reassure people that kick counts have been proven in study to be a good proxy for fetal well-being. Everyone has their own way of doing kick counts, so you would want to talk to your healthcare provider about what they want you to look out for. But blood pressure and kick counts are are the two best proxies for how you're doing in the pregnancy. And a lot of times, aside from those touch points I talked about, vaccinations, labs, ultrasounds, the visits can be done in a telehealth fashion. Now, in the inpatient setting in the hospital, many of you are aware hospitals have been making changes. We've changed our visitor policy throughout the hospital environment, and specifically, I mean, this was an ordinance that came from the SF Department of Health. For obstetrics, our patients are allowed one support person throughout their pregnancy stay. That person can come and go from the hospital if they need to, but the goal is that they stay if they stay through the duration, if possible. And during the delivery, we are now, our hospital, as of the last time I spoke to you guys, we've gone to universal masking so that everyone who comes into the hospital is required to wear a surgical mask. We are asking our patients to wear a mask even in the labor room and during pushing, unless they have significant discomfort with it. But that is all in an effort to help reduce the spread of COVID, especially because we know that there are many patients who are going to be asymptomatic and not have symptoms. I think in the next few weeks, you'll find that many hospitals start adopting universal screening of patients before they come in. Universal testing, because most places are doing universal screening right now. But I think in the next few weeks, you'll see more and more places test their patients for COVID before they, as they come in to hopefully detect any cases that might be present.
And what are you seeing at different hospitals in terms of both visitors during labor and after, in terms of, are you seeing a lot of limitations on the number of people, if doulas are allowed, if grandparents are allowed? What's kind of common right now?
Sure. So I mean, in terms of being in the hospital, I'm most aware of the majority of places continuing to just have one support person. And I know, at least in San Francisco, our amazing doulas have gotten really creative and offered some online support for patients. In the postpartum setting, we're kind of, we have our advice, and our pediatricians have weighed in and said that you should try and limit the number of visitors you have, but it is a personal decision. So if you decide that you really need the support of a postpartum doula or another family member, I think I would just make sure you have an explicit conversation about how you and that other person are going to be isolating and trying to reduce the potential exposures to your family and your newborn, if you do decide to have that support person come.
Great. Well, we have a few more questions around COVID, and then we're going to open it up to some more general questions. Someone submitted a question earlier about advice for pregnant healthcare workers. So if you're someone who's more likely to be exposed, what would you say to them?
Yeah. So this is an interesting one, and I kind of have to be careful how I word this. So as of, let me just go. So as of, I think it was last week, the CDC removed pregnant patients from the high risk category, because based on some recent studies that have come out of New York, we found that pregnant women were not, were able to recover from COVID just like a non-pregnant person. So that prompted the CDC to remove pregnant women from the high-risk category. And ACOG supports the CDC position on this topic. They say that there's no evidence that pregnant women are at higher risk, and therefore ACOG does not recommend additional restrictions. There's acknowledgement that this data is limited, and facilities may consider They say in quotes, consider limiting interactions with patients who have known or suspected cases of COVID-19, and this may especially apply to clinical scenarios associated with aerosol-generating procedures like intubation. So I get this question a lot. A lot of my patients are healthcare workers, and right now, the recommendation is that you talk to your boss and try and limit the type of interactions that you might have with someone, or at least make sure you're using personal protective equipment and you feel comfortable that you're being afforded that PPE, and that if you're working in a scenario that is considered high risk, so in an operating room setting, in an emergency room setting where there might be people who are coughing a lot or might need oxygen masks on, to then think about reducing your exposure and looking for other ways that you can fulfill your responsibilities.
Kind of gotten through all the COVID related questions. We'll use the remaining time to talk about general fertility questions. If people still have COVID questions, just drop them in the chat. We can still get to them, but we did have a bunch of questions that are just more general. So Vanessa was asking what tests you can take to determine whether you are sensitive to folic acid or not.
Yeah, Vanessa, it's not, just checking a serum folic acid level is not going to tell us that much information about whether you're sensitive to folic acid or not. So I generally don't recommend my patients get tested. There are, of course, some patients who are MTHFR carriers where we know that the folic acid that typically comes in prenatals might not be metabolized in the same way, but we're not routinely telling people to get tested for MTHFR. So I wouldn't, the general guidelines from the American College of Obstetrics and Gynecology is for pregnant patients to take 400 to 800 micrograms of folic acid with their prenatal vitamin. If you are someone who's had a history of a neural tube defect in one of your pregnancies, or you have a family history of neural tube defect, or you are someone who has a history of seizures and are taking a medication that we know can interfere with your ability to metabolize folic acid, then you would require higher doses of folic acid. And this is a conversation you should have with your healthcare provider to determine if that would be the case for you, or if there's any reason to test for any conditions that would look for your ability to metabolize folic acid.
Great. Someone asked before, why could it be taking me longer to get pregnant after a miscarriage?
Yeah, I'm sorry you went through a miscarriage. I know that it's always really shitty no matter what the circumstances. We know that it can take anywhere from 4 to 7, 8 weeks for your cycles to regulate after you've had a miscarriage. And one of the things that would be important to know, which I didn't have the context for this question, is was it a miscarriage that happened spontaneously? Did you have to have a procedure like a DNC? Because one of the things that can happen that is very rare, I want to make it clear, is that if you've had a DNC and you're not having a period after 2 months, 2 to 3 months, it's a reason to talk to your healthcare provider, because in that case, I would want to make sure that there's no scarring that had happened in the uterine lining that could prevent you from having a period and potentially being able to get pregnant. But in general, your cycle can be off. If it's been more than 2 months since you've been able to get a period and you were someone who had regular periods before your miscarriage, have a conversation with your healthcare provider to see if there's anything you need to do in the interim to work it out. I think I saw, Halle, another question about how long does it take to start ovulating after going off birth control?
Yes, so Ari asked about how long it takes to start ovulating after birth control, stopped in early Feb, got period in early March, never had a positive ovulation test in March.
So one of the things that can happen, with birth control, the median time to return to ovulation is about 30 days, but it can take anywhere from 1 to 3 months for your cycles to come back. Ari, I'm not quite sure. You did get a period in early March, which is reassuring. One of the things I would wonder is, did you miss your ovulation window? Or, I mean, that could be one of the possibilities, but I'm reassured that you got your period again in April. So I would recommend to start testing again. For someone who has irregular cycles or cycles that you're just getting back into it and you don't know, when you could be ovulating, I think it's using a lot of ovulation tests, but you could start on cycle day 10 and test until you get a positive ovulation test until cycle day 20. Tested for about 10 days straight. My cycle this time was 30 days. Okay, so I would try again this month and check for ovulation. Based on what you're telling me, you should be ovulating, hopefully. And if you don't, then I would reach out to your healthcare provider and talk about if there's anything else you should be doing, or the test that you're using, or if there's anything else nuanced about your history that would require more information.
Great. Catherine has a great question. She is pregnant in SF, and all of her family's on the East Coast. Her best friend is also due soon, which, Catherine, that's going to be so much fun. Having friends with kids the same age is great. But she's wondering about visits at home. Should they stay away? Or could they, if they're both self-quarantining, can they safely visit each other? I love this question. What do you think?
Yeah, I love it too. And I think it's a very personal one. I think you have to understand, like, most medical opinion is going to be on the conservative side and say our recommendations are to self-isolate. But I think if you are both self-quarantining for a 2-week period and you have very limited interactions with people, and none of you are, neither of you have partners who work in high-risk position, high-risk jobs where they might be exposed to COVID, it's something that you can consider. And I think it would, be able to, you would be able to get some support, especially in a time when your family did have to cancel. So definitely something that I would entertain. I think it's a very personal decision, but as long as you're both healthy and, like you said, limiting the amount of interactions you're having in that 2-week window, that's an innovative way to think about support during this time.
Yeah, great. So Caroline asked if CoQ10 and vitamin D are good complements to prenatals.
Good question, Caroline. I tend to keep it very simple with my with the supplements that I recommend for my patients, which are prenatals and DHA. We do know that most people are vitamin D deficient, so I think it's very safe to take vitamin D. And CoQ10, I know, has been studied for some patients who have PCOS. I don't routinely prescribe my patients CoQ10, but I think it is it's very low risk and would be very safe to take if you want to.
Natalist has a CoQ10 product that is coming out very soon. It's on pre-order, so you can learn more about it on the website, and we link to all of the research behind it. So if it's right for you, you can support Natalist and get them from us. Okay, Georgina has a question that she says is TMI. Nothing is TMI for an OB. Let's just say that.
No, exactly.
She says her March period was quite weird, excruciating pain the day it came in, spotting earlier than normal for days, 2 light period days, not almost a period, and all of the symptoms since 3 to 4 days post-ovulation up until spotting began. My April period was earlier as well, and weird. Could it be something was cooking in there but did not succeed? I know for a fact something was and felt different. Tested about a week before my period, but it was negative. Thank you.
What does DPO stand for? Yeah, it's my period. I'm just rereading it again because I have to. It could, Georgina, I don't know how satisfied you'll be with this answer, but yes, it could have been. Sometimes people can have a chemical pregnancy that where maybe the HCG levels were not I mean, usually it'll pick up on a UPT, on a urine pregnancy test, but if the pregnancy hormone levels weren't high enough, then it wouldn't have been detected. My recommendation for you would be to keep track in this next month or two and potentially check in with your healthcare provider via telehealth visit. But you know your body better than anyone else. And I'm just having a window into 1 month of your menstrual cycle. If you had been trying that month, it is possible that you had a chemical pregnancy. It's hard to say, but I would continue tracking your cycles and continue trying to conceive if that's something that you want right now. Hope that was helpful.
And I would suggest taking another test closer to the missed period too. All right, so we had a question beforehand that someone submitted, recommendations on trying to conceive with an older male partner, 45 years old.
Yeah, some of the questions I would have for that is, has this partner had children in the past with anyone? If so, that's reassuring. We do know that there is data to suggest that sperm quality does go down for men. It doesn't have the same, at this point, the research doesn't show that it has the same effects on increased chromosomal abnormalities that it does for, women and their eggs and their egg quality. I would say that I would continue trying to, the same kind of recommendations apply given the age of the individual. If they're over 35, I would try for 6 months, and if unsuccessful, reach out to a fertility specialist. Potentially consider going forward and having a semen analysis done on the sooner rather than the later side, because if the semen analysis is normal, then there's no, there shouldn't be any barriers from that, from the male fertility standpoint in trying to get pregnant.
I'm not sure if you have an opinion on this, but best drinks other than water when TTC and pregnant.
I would say water is the best thing that you can have, but just because you're trying to get pregnant, I don't know if you meant best drinks like non-alcoholic.
Non-alcoholic.
You can have, you're allowed to have caffeine, so 200 milligrams a day. So if you want some cups of tea or a cup of coffee a day, you can do that. Obviously, like juices and sodas, we recommend, even if you're not trying to conceive, to try and limit your intake. Because we know that sugary drinks can increase pre-diabetes and diabetes. So I don't think you have many options off the table, with the exception of alcoholic drinks.
Great. We're going to wrap up soon. So if people have additional questions, let's get them in. Caroline just asked, what's your recommendation if you've had 2 miscarriages and first round of IVF retrieval came back with 2 irregular embryos? Are there things you can do to improve the outcomes through healthy eating and staying fit?
Caroline, I'm so sorry you've had to go through this. I would say, this is a great conversation to have with the doctors you were seeing in reproductive endocrinology and infertility. My recommendation would be, so in terms of if your question is about, are there any specific diets and that you should be following during the TTC period, there's no data that I'm aware of that says you have to have a specific diet. So while we know that there are benefits to a plant-based diet and that some people might have gluten allergies or sensitivities, it doesn't, I don't tell my patients who are trying to conceive to abide by a certain diet, but I will say I do have colleagues in the field of infertility and endocrinology who, for certain patients, will ask them to follow a specific diet, which is why I'm hesitant to give any concrete. I don't have the concrete advice as to what diet you should follow. And that would be a question, I would say a healthy diet with moderation, and something that keeps you happy. I would talk to your fertility specialist if there's anything that you need to do. And staying fit, I mean, I recommend to everyone, no matter where they are in their journey, to exercise and to have at least 3 days a week of like intense cardio, and to try and do something that also helps keep you relaxed as well.
Few last questions. Vanessa asked, should women avoid drinking and using substances while TTC?
Well, I would say yes to all substances. We don't have any, I mean, the information we do have on some substances is that they are harmful for the fetus and should not be consumed while trying to conceive. I think the data on cannabis is mixed, sorry, I shouldn't say mixed, it's inconclusive. And so I tell my patients to avoid it during the time to conceive. Drinking, if you read the American College of Obstetrics and Gynecology, the recommendations are for no drinking during the time to conceive. The studies that have been done on drinking are, one, it's going to be hard to study people, right? Like, imagine telling people, I want you to have 3 glasses of a wine a day and try and conceive, and I want you to have none. Like, let's see what the outcomes are going to be. We can't run those kinds of studies in obstetrics. There have been some Danish studies that have showed that with minimal alcohol use, there are no increased fetal outcomes or risk for congenital anomalies. I tell my patients, if you want to have a glass of wine here and there while you're trying to conceive to help like put your mind at ease or to maybe even get you in a mood, that's fine. But I don't want this to be, if you are actively trying to conceive, please try to be mindful of limiting your alcohol use.
I think we've gotten through most of the questions. So we'll let you go back to doctoring. Thanks so much for letting us pick your brain today.
Absolutely. And just something for our audience to know, like, I know it can be really scary if you are worried about having a miscarriage during this time, or maybe you were trying to conceive and you decided to put a pause on things. Please know that your providers are still there to provide you care. So in terms of contraception, there are many options that are available to you that don't require an in-person visit. And if you are someone that does want something that's more longer acting, have a conversation with your provider to see if it might be right for you to come in for that. And in terms of miscarriages, we are still going to take care of you. And I know I saw this article that broke my heart about people who are going through miscarriages at this time feeling very alone and not having that same support. But as your providers, we're here to support you. We will continue to see you. We're not going to make you do these things alone. So on that note, I'm happy to talk to you guys at any time. Halle, thank you so much for organizing.
Yeah, and everybody, you know, Naz and some other physicians have written some really great content for us at, sorry, you can hear my 2-year-old in the background. At natalist.com/learn, we have an entire section for COVID questions, as well as a ton of other great content. So please use this time to dig in, and we just want to support you all in your journey. So thank you everybody for coming, and thank you, Dr. Naz, for chatting with us.
You're so welcome. Good luck, everyone.
All right, bye.